there's a lot of stuff to run through today, but a lot of it is either repeat or not things that you need to dedicate a tremendous amount of time to going through. But upper and lower motor neuron and upper and lower motor neuron injuries, there's a lot of like specific details you can get into. Really, a lot of this stuff, it's easy to get lost in the weeds, but they ask about very specific things, so I'll talk about those very specific things, and everything past that is really more just your guys knowing for your own sake. But anyways, so basically, upper and lower motor neurons. Anything, I know I said it in one of the other tutoring sessions, anything that isn't the last neuron that synapses directly onto a muscle is an neuron, an upper motor neuron. So, and the goal of the main job of the upper motor neurons in a lot of cases, obviously, the tracks carry signals down, but is in regulatory. And it's because they're carrying signals and constantly being toned back by like the basal ganglia and the cerebellum. So when you lose the upper motor neurons, you tend to get hyperactivity of the lower motor neurons, and the reflex arcs go a little crazy, and they kind of do whatever it is they want to do. Conversely, when you lose the lower motor neurons, it doesn't matter what signals you're sending down, they don't make it to the muscles. Therefore, you get weakness, loss of reflexes, things like that, with lower motor neuron injuries. If you just basically understand that, and like I think I mentioned before, a lot of times I've heard it described as like the upper motor neuron to the parents, and they're always keeping the kids in line, the lower motor neuron to the kids, and when the parents are gone, the kids tend to act up, right? So yeah, so as far as lower motor neurons goes, your spinal cord, right? They project out the ventral horn. So this is what's like affected in usually like ALS when they start to lose motor function. This is what's affected in polio. And then for the brainstem, for the cranial nerve motor nuclei, which is really just the middle ones. And then the upper motor neurons, it's really everything else. I have examples here, but it's really, really, really just everything else. So it's very the only, I shouldn't say the only, but the very overwhelmingly important thing here is to be able to look at somebody's symptoms and say these are either upper or these are lower motor neuron symptoms. And again, the way that you do that is if it's a hyperactivity or spasticity, it is going to be an upper motor neuron injury. If it is anything, hyporeflexivity, atrophy of the muscles over time, you're going to have that is a lower motor neuron injury. And sometimes they'll really ask it to you both ways. They'll either give you the symptoms and you have to explain what it is, or they'll say this person has this injury here. What signs and symptoms do you basically expect them to have? So an example would be they'll say like the patient has a lesion in their anterior horn, and you need to say to yourself, okay, that's a lower motor neuron injury. And then the answer choice might be like hyporeflexia, or it might be atrophy of the muscles. And a lot of times when they're talking about the lower limbs, they'll talk about the Babinski reflex, right? So the Babinski reflex is something that appears when you lose upper motor neuron like regulation, right? They talk about that a lot, right? That's like the fanning of toes that you're supposed to lose when you're like 2 years old or something. It helps us walk, I guess, when we first don't know what we're doing. Right? The characteristics of the lower motor neurons and kind of how like they're arranged in motor units, you should be aware of generally how this works. You should be aware of like the general trends, but you don't need to be hyper specific about any of this, right? So it's important to know, just because this is not gonna be like a question where they ask you to give this definition, but they might use these terms in questions, and you need to recognize that the motor neuron pool is all of the neurons that innervate all of the fibers in the same muscle, like the whole muscle. So the gastrocnemius muscle, your left, right, has one motor neuron pool. And then the motor unit is the delineations within that muscle, the bundles of fibers that are innervated by one single neuron that's going to that muscle. And it's really simply, the bigger the motor unit, the bigger the motor neuron, which makes sense, right? If you're innervating more muscle fibers, you need a bigger signal, you need a bigger neuron, right? Generally speaking, Large motor units have a high innervation ratio, which means one neuron for a lot of fibers, right? Whereas smaller motor units, it's the opposite. It's more 1-to-1. And basically, if you really think about it, in what cases would we need these? Well, when we need more nerves per muscle fiber, essentially. You want to do this when you need fine motor control, right? Because it's going to be like really fine, detailed movements of a lot of things. When do we need to use have one muscle and a bunch of fibers in that muscle do the same thing all at once? Well, when we need strength, right? I don't need to control each muscle fiber in my leg independently when I'm going to jump. I just need to tell them all, hey, I'm going to jump. Whereas something like facial expressions or in your hands, you need to be able to send more signals to more delineations of signals to muscle groups to have a little bit more fine, delicate motor control, especially because one of the things, the main ways that our body controls how much effort we're putting into lifting something is by how many of these motor units we're actually recruiting. The only other thing that you should know is the white fibers versus red fibers. Red fibers are red because they have a lot of myoglobin and they have a lot of mitochondria. Because they have a lot of myoglobin and mitochondria, they fatigue slowly. The white muscles, the white fibers, they fatigue easily. They shoot their shot, then they're done. They need to recharge, right? The red fibers, they're consistently go, 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 go. And this is just a graph that just shows basically everything I talked about. But it makes sense, right? And this is what I was talking about with the force recruitment, right? So the muscles that are slow to fatigue are the ones that we use all the time. The ones that are fast to fatigue are the ones that we don't use that often, right? But it's not like an endurance thing. It's just you don't need these muscles to keep doing the same thing over and over and over and over and over and over and over again. The reflex circuits they like to ask about a lot. So basically there's two different feedback loops that tell your body how much force is being exerted on a muscle that prevent us from hurting ourselves, right? So you have the muscle spindle. These are little receptor bundles that are in the muscle fiber itself, like in between the muscle fibers themselves. And these are really responsible for like how stretched the muscle is. So this is how our body kind of orients in space. Technically how long the muscle is, but really like how high we're lifting something, right? So like if I want to like lift this can, right, and I say I want to lift it up to my chin level, my body knows roughly where my arm has to be to hold itself at chin level, right? And this is kind of how this is the feedback loop to where my body knows like, okay, this muscle needs to stretch more or this muscle needs to stretch less, and it's how you hold something stable in space, right? The important thing to know here is that these fibers are in the bundles. If you really want to, you can learn like which neurons innervate these. But I'm gonna be honest with you, it's unlikely you'll get a question on this that you won't be able to just like figure out if you know what all these neurons do. There was like that one chart that's like, oh, these are responsible for pain. These are responsible for sending motor signals from like the first tutoring session. I think I might have put it in here too. And if you just know that, you can usually figure out anything you need for these questions. But the important thing is that the muscle spindle is located inside the muscle bundle, in between the fibers, and it regulates length. Right? So as it stretches passively from the weight, your body says, I like this example because it really kind of shows how like if you try to hold a cup still and you pour water in it, your arm starts to bend down, your body sees the muscle stretching more. Your body isn't saying that muscle should be stretching more, so it applies more force, right? Recruits more motor units. This is a myotactic reflex. This is called the myotactic reflex. Another important thing that you need to know, only because sometimes they'll ask a question, they'll ask which reflex is like responsible for this, and the answer choice won't be stretch reflex, it won't be myotactic reflex, it won't be deep tendon reflex, right? It'll be monosynaptic reflex. And the reason why this is the monosynaptic reflex is because you're sending one signal to the anterior horn, and then it's sending one signal back to the muscle group, right? Yeah. And the way that the body generally works, also in all of these reflexes, do not forget, because sometimes they'll also ask this. In any of these reflexes where we're measuring how much force is applied to one muscle, and this is more true for the Golgi tendon reflex, which I'm about to talk about. it applies the opposite, whatever signaling this reflex is sending to this muscle, it's sending the opposite reflex to this muscle. So if your body is telling your bicep to contract, it's telling your tricep to relax. That can also be like a question they ask, because they'll basically be asking a question and be like, oh, well, the bicep's going to contract. Won't be an answer choice. Relaxation or inhibition of triceps will be like an answer choice, right? So it's you got to think about that. Golgi tendon organ. This reflex is located in between the muscle. The nerves for this reflex is located in between the end of the muscle and the tendon that attaches to the bone. And this is responsible for telling your body when you're holding too much weight. So if you try to pick up something really heavy and your body says, nope, can't do it, and your arms just let go, right? I don't know if anyone's ever tried to if anyone's ever lifted, right? You'll try to go up. And then it's not that oh, I almost can't make it. Your body, you just lose all strength, right? For a second. And it's this reflex telling you that, hey man, you're going to hurt yourself. And so sometimes they'll talk about how this is in series. You remember anything about like resistance, right? From fluid dynamics from Cavrar. This is in series, whereas these are considered to be in parallel with the muscle fibers. But yeah, as long as you know which muscle reflex is responsible for which, whereas the spindle is responsible for stretch, and this is responsible for too much force, protects you from heavy loads, you should be okay. And then this is what I think a lot of people think of when they think about reflexes. This is the flexion jaw reflex. This is, I put my hand on a hot thing and I pulled it away before I realized it was hot, right? Usually your arm is already moving by the time you've processed that you've touched something you weren't supposed to, right? This is the reflex that does it. Something that is important to know is that if you step on something with your right leg when you're walking, yes, your right flexor is going to contract and your right extensor is going to relax to allow you to withdraw that leg. But the opposite happens on your other leg because you need to maintain balance so you don't fall over, right? So right flexor will contract, right extensor will relax, left flexor will relax, left extensor will contract, right? Not too hard to kind of rationalize, but very important. And this is a polysynaptic reflex. Why is it a polysynaptic reflex? Because it's hitting everything. These are the things you really need to know. They don't ask about this too much, if I'm being honest. But it's a really good summary. If you're a flashcard person, you won't need to know anything that's not on here. But these two are the ones they ask about a lot. Know the difference between these. The other thing I like to kind of point out to help you remember this is Golgi tendon reflex. If you ever hear stories, now whether or not these are actually true is up for debate, but about a mom lifting a car off her kid, in theory, they're suppressing this reflex. And that is why they probably would end up with all kinds of problems afterwards, right? And then again, upper versus lower motor. This is most of the stuff, right? Your flaccid paralysis, your hyperreflexia, your hypotonia, your muscle atrophy. So the thing is, with fasciculations and fibrillations, I think people mistake for spasticity sometimes. Fasciculations happen because the muscle is receiving no input and doesn't really know what to do, and will occasionally just, hey, use it or lose it. I got to do something, right? As the muscle starts to die, it'll start fasciculating, right? Lower motor neuron lesions, upper motor neuron lesions. Babinski sign is huge. Spasticity. This is sort of spasticity, right? This is another good one, right? Just another quick little didn't go over. They talk about class knife sometimes. But you can just think it's a spasticity, right? Spasticity, upper motor neuron lesion. Your cortical bulbar tracts, right? So these are basically responsible for your cranial nerve motor function, right? We talked about cortical spinal tracts pretty extensively, and then we talked about brainstem injuries. but they have these separated out here. In retrospect, we probably should just talk about these when we talk about all the tract lesions, but here we are. This is just the path that the motor nerves take to get to the cranial nerves, right? So they come down from the motor cortex, and then they cross over to their associate nucleus. This is why pretty much every cranial nerve lesion is ipsilateral, because the cranial nerves are the lower motor neurons, right? The other thing to note, from this part of the precentral gyrus, right? The bottom part is the face. The top part is, the rest of the body, right? So you have like your arms, and then this is notoriously like your legs, right? ACA territory. So MCA, the real point of this is like MCA supplies the face. You got to be careful sometimes, because in theory, this is sort of where like Wernicke and Broca's areas are, right? And this kind of like vaguely in this territory, not on this diagram, right? Because this is a slice of the precentral gyrus, but like if you were looking at the brain from a profile view, it would be like at that same level. And sometimes a question stem will talk about somebody with difficulty talking, and you need to just distinguish in the stem whether or not they're having a difficulty talking because they have some type of aphasia, or whether they're having difficulty talking because their tongue's not working, right? Or their lips aren't working. And a big thing for this is Bell's palsy. So basically, if half of somebody's face is paralyzed, that's okay, because it is probably a seventh cranial nerve lesion. Maybe just like some type of neuritis, right? That might fix itself. If only the bottom corner of their face is paralyzed, that is a problem, because that means that the problem is coming from the cortex. And the reason is because the top of your face gets bilateral innervation from both motor cortices. So the only place that you could have a lesion that knocks out half of the face is if it's after the facial nuclei. Whereas if you are missing the bottom half but not the top half, then the lesion has to be before the facial nuclei, which means it's a problem in the cortex. Or I guess it could technically be, as it comes down to the internal capsule. But the point is this is Bell's palsy, half the face. It's cranial nerve 7 neuritis a lot of times. This is a stroke. And so you talk about the tongue paralysis, right? Now, this is a tricky question that I almost guarantee you will have on your exam. Some permutation of this question. It's not going to be like this exact question, but some permutation of this question. Here's why. A lesion in your right corticobulbar tract will push your tongue to the left. A lesion in your left cranial nerve 12, right, will push the tongue to the left. So they may ask you a question where they will talk about a person who's having issues speaking, their tongue, when they stick out their tongue, it deviates to the side, and you're immediately going to think, okay, this is a, if it's pushing to the left, it's a left medulla injury, right? But you have to look for them to describe whether or not there are fasciculations in the tongue, right? Because if there are fasciculations in the tongue, that makes it a lower motor neuron injury. If there are no fasciculations in the tongue, it is probably an upper motor neuron injury. Sometimes they will talk about the tongue. It sounds like they're just, it's so stupid. I know it's so stupid, but sometimes they'll be talking about like writhing, worm-like movements of the tongue. That's not fasciculations. It's fasciculations in any other part of the body, but in the tongue, it's spasming, right? And that makes it an upper motor neuron injury. So they'll ask you, and they'll tell you it deviates to the side, and you have to look to see whether or not there are fasciculations to determine whether it's a lower or an upper motor neuron injury in this one specific way that they asked the question, but I'm pretty sure they asked it on our in-house exam. I'm positive I've seen it on UWorld. I'm positive I've seen it on AMBOSS, and I'm pretty sure I saw it on one of the forums. So just, this is a very good way to test how much you actually know about nerves. And this is just all the other ones. I just do these all in one thing because you should be aware of what they do. But two things. One, you know immediately what every single one of these does by just its name. You figure it out in the exam, right? Two, They don't ask about these very often. Basically never. The other like reflex stuff and like the other lesions are so unbelievably high yield that a lot of the other stuff in neurology just gets left to the wayside. But definitely be familiar with all these. All right. So then on to the cerebellum. All right. So the cerebellum is actually about half the brain as far as like when you're talking about like neuron numbers. And the reason for that is because the cerebellum is continuously planning and adjusting your movements, all of your movements. And it does it without our knowledge or input, right? So it's basically like a second brain, right? The cerebellum translates literally to little brain, right? If you have ataxic problems, it's either a problem with the cerebellum or it's a problem with the basal ganglia, which is what the cerebellum talks to us through, right? Talks to the rest of our body through, right? So it is responsible for basically any movement, like not I'm going to move my arm, but we consciously say I want to move my arm. The cerebellum figures out how to do that for our body and then tells our body to do it. The other thing too that a lot of people don't think about, the cerebellum is also responsible for muscle memory. So it also talks to like the Papez memory circuit loops and stuff because it's just responsible for planning or for muscle memory. And because of that, if you have problems with the cerebellum, even though it's like really 99% of the time just for ataxia, you can have cognitive impairment as well. You should be generally familiar with the way that the cerebellum's laid out, but they're really not going to ask you about a lot of these things. Generally, when they ask you about this, they're asking about, is it the left side? Is it the right side? Is it limb? Is it distal ataxia or is it truncal ataxia? They're almost, again, this is another one. Be familiar with these things. Don't super worry about it. You're not likely to get a question on this. If you do get a question on this, it's going to be like one of those hyper specific weird questions. So just be generally aware of how the cerebellum's laid out. Do not agonize over the name of every bit and piece of it. You'll probably get 2 questions on the cerebellum. One of them will be a lesion where you have to say whether it's in the vermis on the left side or the right side. The other one will, who knows what it'll be, right? But this is what you really need to know, right? This little weird homunculus that lays over the cerebellum. Truncal ataxia will be in the middle, and then it moves out to your limbs. That is the most important thing of understanding the shape of the cerebellum. You can read through and slightly remember all of these things, but this is overwhelmingly the important part of this. And then knowing how it projects, right? So I wish I would put this on the previous slide, like together, but it is what it is. This is really just to illustrate the pathways, right? If you know what like the dentate nucleus, right, does, you can kind of figure out that this is like the projection path, right? And I mean, really, the same thing for you don't need to know the names of this, right? This isn't super important, but knowing generally what these are for is something that you should learn. But overwhelmingly, you need to know how this is laid out, right? I mean, it kind of makes sense, right? Like if you remember that the hum nucleus is in the middle, like over the vermis, right? Which is how they'll ask about this a lot of times. Well, that should make sense to you. Then it's responsible for like the actual movement and muscle tone. And then like the rest of it, the meat of it is just responsible for everything else, right? And then you have these like little things that hang down that are responsible for like balance. These are only balance. These talk to like your vestibular system, right? But like again, vestibulocerebellum. It's this part of your cerebellum that communicates with your vestibular system. What does the vestibular system do? Controls posture and balance. Spinal cerebellum. It's a part of your cerebellum that communicates with your spine. What does parts of your brain that communicate with the spine do? Controls motion. Cerebrocerebellum. It's the thinking part of your brain. It talks to the thinking part of your brain. What does it do? Plans everything, right? So you can just break this down. You do not agonize over this. Just think about it and hope they don't ask you these names. I've never seen any of these names, but I've also never really, to my knowledge, seen them ask us these specifically either. So it is what it is. If a question exists in the bank, he's going to put this on the test because this is a pretty cool thing. It's kind of a pretty big deal into how things actually work, but not super high yield. And interesting things that aren't super duper high yield but are important to understand are perfect questions to put on in-house exams. Main takeaway here, Purkinje cells are inhibitory. If you learn anything from this slide, learn that Purkinje cells are inhibitory. Now, should you know that it goes mossy fibers into granule cells, which then terminate on Purkinje fibers, which then do the inhibitory processes on the cerebellum? Yeah, I would know that order for sure also. But if you leave this slide with only one tidbit of information, please God, know that Purkinje cells are inhibitory cells. Yeah. The cerebral peduncles, you don't need to know the Latin names. I don't think you need to know the Latin names. But again, do know that the superior peduncle is responsible for the efferent pathways, and the middle peduncle, oh, cerebral, sorry, superior. It's really like here, right? And it's just like cut away. And the middle is responsible for the afferent pathways, right? So it comes in the top, or I'm sorry, it comes in the bottom and it goes out the top, or it comes in the middle. It's really the middle. It comes in the middle and goes out the top, right? And then your the inferior again is the vestibular system, and it's the same order as we talked about here, right? Like the vestibulo, cerebral, spinal. So if you want to internalize this, even though they refer to them as superior, middle, and inferior, you can also just kind of slap on the spinal, cerebral, vestibulo, however you want to memorize it. But do know that these are the efferent pathways and these are the afferent pathways, right? Signal coming into the cerebellum comes from the motor cortex. Signal leaving the cerebellum goes to the thalamus, right? Because before it comes back down, right? And you can see that here, right? This is the actual motor loop, right? So our cortex sends a signal down to the olives, which then project to the middle cerebellum, right? The middle peduncle, which then project back to the thalamus. And then they tell our brain, hey, if you want to walk there, you have to tone back those muscles a little bit. You have to increase those muscles a little bit. And this is happening tens of thousands of times a second, right? This feedback loop. It's just going and going and going and going. Brain says, this is what I want to do. Cerebellum says, this is how you do it. Yeah, and this is the same thing, right? This is just what I talked about, but in more detail. Again, you don't need to know super specific things about this. Just generally know how the system works, where the stops are along the way, right? Cortex to pontine to cerebellum, up to the thalamus, back to the cortex. Just know that for sure, right? So then talking about lesions, you have truncal ataxia, right? I get this wrong every time. I don't know why I can't internalize this, but know that when you have truncal ataxia, right, which is going to be a vermis lesion, you think about the little homunculi, you're going to lean towards the, even because my problem is oh, truncal ataxia, it should be the middle, right? The middle of the vermis. What do you mean there's a side? Yeah, it goes towards the side. You lean towards the side of the movement. This is the hand flapping thing that you guys did in your OSCE today, right? Dysmetria is the other test you did, right? These are all OSCE tests, right? This is just vocab. Know these. Just know these. Yep, this should all make sense based off of literally what we just talked about a second ago. It makes sense. Spinocerebellar. If you have a lesion in the vermis, you're gonna have problems moving, right? So you're gonna get ataxia, problems with gait. You get all those motor function problems. Then if you're cerebrocerebellar lesions, now you are having problem regulating your movements. So you're having problem like kind of like planning them out. So anything that requires any type of muscle memory or anything that requires any type of like intricate, complicated movements, you're going to be like tripping over your own hands, right? And then your vestibular lesions, this is all your oculomotor disorders. So if you have like a nystagmus, if you see a stem that says you have a nystagmus and it's asking where in the cerebellum you have a problem, it's in the vestibular. There's a couple diseases they throw in here that should really just be lumped together with all the other ones. But so Friedreich ataxia, right? This is super important. Know all of the triplet repeats. Know what they all are and know what chromosome they're on. They ask so many times they ask about it. So many times the answer is just GAA, trinucleotide repeat, or trinucleotide repeat expansion. They'll give a stem. They'll talk about this ataxia. And a lot of times for Friedreich ataxia, they will give you that they have heart problems also. But so often is the nucleotide repeats talked about. You should know that's frataxin. That shouldn't be too hard to remember, right? Frataxin, right? Yeah, that's pretty much it. The other thing with the big one of these is look at the age of the person. And as we do, I do have practice questions for you guys. A lot of times the age of the person just gives these questions away also. But I cannot stress enough how important it is to know this. And honestly, they ask more about this, the etiology of the disease, than anything else. I've definitely seen questions also about this part, the frataxins of mitochondrial protein, and they become more susceptible to oxidative stress because they can't handle iron properly. I'm pretty sure that I had a question that it was Friedreich ataxia, and it was really obvious that the patient had Friedreich ataxia, and the actual like answer choice was a mitochondrial oxidative stress. And I got it wrong. I remember reading the description. I'm like, what? Come on, that's so far removed. But just know this. The etiology is the important thing here. Usually, by the time you take the test, you'll know all of these, what they present like. Really, these are the things that they ask because these are the answer choices they give you to give. Lysosomal storage disease. I don't know why they choose to pick this one. Listen, if I can tell you one thing, if they are ever asking you a question about a lysosomal storage disease and it's not in ICEL or Hunter-Hurler, they're going to be asking you to distinguish between Niemann-Pick and Tay-Sachs. And in question stems, the only difference between Niemann-Pick and Tay-Sachs, 9 times out of 10, in a question stem is hepatosplenomegaly. Niemann-Pick disease has hepatosplenomegaly. Tay-Sachs does not. Now, that being said, cherry red macula will be like an answer choice a lot of times, the correct answer choice. So you just can get lucky sometimes because it answers for both of them. But this is your big giveaway. I've also seen questions about foam cells and zebra bodies. A lot of times, like I said, if they're asking about this, it's usually, can you distinguish it between Tay-Sachs disease? Know the genes, know what they do. Dirty Man has a really good video on all the lysosomal storage diseases. I highly recommend you watch it. I think it's 12 minutes long. Super good. Super dirty. But yeah, those are the two types of like ataxic disease. I thought I had Wilson's disease in here, but I guess not. Did we talk about Wilson's disease already? I thought I was in here. Real quick, Wilson's disease, right? You have a problem with the ABT7A protein or whatever it is. You can't process copper. Copper is neurotoxic. It prefers for some reason motor neurons. So you get ataxia. 9 times out of 10, they ask you the question. They're going to either be asking you about serum ceruloplasmin levels, which is like the protein that like your body uses to bind to copper. So in Wilson's disease, no, you know what? I know for a fact this is sliding. I'm going to stop. We'll get to it. Strokes. This is going to bug me now. Now that's out of order. We already talked about strokes, right? When we went over blood supply to the brain. If you know what the sections of the brain do, you know the neuroanatomy and you know the blood supply, you should be able to answer every stroke question. So then the only thing that you get to is, this is one of the things they like to ask about risk factors a lot. Know the difference between non-modifiable and modifiable risk factors. That's all I can say about that. Know the difference between a thrombotic stroke and an embolic stroke. Embolic strokes happen quickly. Thrombotic strokes happen over time. because this is a clot that was formed somewhere else being shot down into a vessel that's small, whereas this is just continuously narrowing of the vessel. If the patient has had symptoms for less than 24 hours and then they resolve spontaneously, it wasn't a stroke, it was a TIA. It's another important distinction to make. Somewhere, I don't know where it is. I spent like 40 minutes looking at it, to be honest with you. I couldn't find it. There's a stratification of which one of these risks outweighs the other. I don't know what the most important thing to cut back is, to be completely honest with you, to reduce stroke risk. And that is something the type of question they like to ask. I would see if you can find, because I couldn't find one, maybe I'm just stupid, an actual source that tells you what the most important thing is. I believe it's hypertension. I believe in order to reduce stroke risk, it's hypertension, diabetes, smoking, and then AFib. Because the problem with AFib, right, you have turbulent blood in your heart. The left atrial appendage, the blood doesn't really flow in and out of it because the blood is turbulent in the atria. So it forms like a spot for the blood to coagulate, and you get a little clot in the left atrial appendage. And then when you fix the AFib, either by treating them or they spontaneously drop out of it, now that clot gets dislodged because the heart is pumping properly, and it shoots up into the carotids, right, into wherever. Large versus small. You should already be familiar with all these because, like we talked about, lacunar strokes and structural aneurysms. It's not super important to know the difference between large artery and small vessel occlusion. You just need to know all the things that, like, in general, fall under the umbrella, right? We just talked about this cardioembolism. It should make sense to you that if you have large artery atherosclerosis extracranially, it basically has to be in the carotids. And if you have intracranial atherosclerosis, and these are the important thing to know here is these are the thrombotic lesions, right? Then it's got to be in the circle of Willis, right? And then here you have the small vessel occlusions. These are usually either emboli or they're due to hypertension, right? So you'll have these are like kind of like you'll have like hemorrhagic strokes like this, right? We talked about your lacunar strokes, your Chicago-Bouchard aneurysms. These are usually in the lenticular striated arteries, which supply the basal ganglia in the internal capsule. So you get motor loss with these usually, right? And this is just what it looks like on the scan. Hemorrhagic stroke. I guess I should have mentioned this. So technically, we think of strokes as like blood clots in the brain. Technically, a stroke is any event that eliminates blood supply to the brain, causing permanent neurological damage or long-term neurological damage. So if you just lose a lot of blood, either because you have an intracranial bleed or even if you just have hypovolemia from like trauma, technically even that can be considered like a stroke event, right? But usually when they talk about hemorrhagic stroke, this is what they're talking about, either an intracranial bleed or a subarachnoid. These don't get harped on too much. The delineations between all these very rarely get harped on. If they're asking you a stroke question, they're almost always asking you either, can you localize the stroke based on the symptoms? Do you know what caused the stroke based on like, oh, this is a lenticular striated artery stroke, so hypertension because it's Chicago-Bouchard aneurysms, right? Those are the kinds of things they ask. They don't usually ask these kinds of questions. TIAs, this happens. If you talk to anybody who works in like an ER, they'll tell you that these are probably wildly underdiagnosed, like stupidly wildly underdiagnosed. But because they last for less than half an hour and they've got a lot of really weird, like basically any type of head brain deficit, which also overlies with things like, I don't know, panic attacks, sleep deprivation, benign positional vertigo, right? It's hard to diagnose these. Especially since like it says here, like they resolve super quickly. But the important thing, and the reason why we should do a better job of diagnosing these is 50% of people diagnosed with a TIA, so this is probably higher than the actual number, will have a stroke within a year of this presentation to the hospital. Now you can argue if you all you want, well, is that because that these like super duper predispose somebody to having strokes, or is it because by the time you see them in the hospital, this has happened to them enough times where their families convinced them to come in? I don't know. But TIAs have the same risk factors as a stroke: hypertension, diabetes, CAD, AFib, smoking. if you get a question on this and they are asking you, is this a TIA or is this a stroke? You need to look for two things. How long did the symptoms last for more than 24 hours? And do they have permanent symptoms afterwards? If it has lasted for more than 24 hours or they have permanent symptoms, they want you to say it's a stroke. If they have no permanent symptoms, and it's lasted for less than 24 hours, they want you to say it's a TIA. We don't really need to go over this. You guys remember this pretty well, right? ACA territory, MCA, right? Just remember the ACA, MCA. Know what the parts of these do. That is 9 times out of 10 the question they'll be asking you. Know the aphasias. Also, there are subcortical strokes, right? Brainstem strokes, cerebellar strokes, basal ganglia strokes, internal capsule strokes. This is normally the type, if it's a stroke question, they're usually asking you about this unless it's a internal capsule stroke or brainstem lesion. Cortical lobar strokes, as far as like the person had a stroke, where is it, is a lot higher yield. And a lot of times it's because they're talking about the aphasias. If you see bitemporal hemianopsia with macular sparing, this kind of stroke, right? If you know what these things do, you know what happens when you stroke them out, right? Again, brainstem, internal capsule, these are the ones that get asked about a lot because it's like localize the motor lesion to the side of the head. Cerebellar, they don't ask super a lot about, like specifically, like where in the cerebellum it would be. Like if they're gonna ask about a cerebellar stroke, the answer will just be the cerebellum. And it will talk about like ataxia or something, or it'll say that they have ataxia, or they'll say they have a cerebellar stroke, and you have to say like, oh, they'll have ataxia. The other thing to note is know the Romberg test, because sometimes they'll give you like a cerebellar lesion or like even like a vestibular lesion, and then they'll ask you like, would the Romberg test be positive or negative? I would just remember that the Romberg test is when your eyes don't agree with what your body's doing. So a lot of times you'll have cerebellar strokes and the Romberg test will be negative, which seems counterintuitive, right? But it's really, the Romberg test is more like a vestibulo-ocular thing. So no, if you're not familiar with that, I know you guys just had your OSCE today, but I 100% did my OSCE knowing how to do the Romberg test without really understanding what specifically we were testing. So just familiarize yourself with it. Watershed strokes. This is just like the watershed problems in the gut, right? Anywhere you have, they're not quite anastomoses, not technically, but where you have two vessels supplying blood to the same area distally from the supply of those vessels, that's where the vessels are the smallest. Therefore, this is where the blood supply is most at risk, either due to emboli or global hypovolemia. You'll see these wedge-shaped lesions, and they're always right here because this is where the ACA meets the MCA, and this is where the MCA meets the PCA, right? If you remember the homunculus, you remember generally how this is laid out, right? You lose half your field of vision. The reason you lose half of your field of vision is because, and I know you look and you're like, okay, well, this is the PCA and the MCA, right? So this is kind of like the occipital lobe, right? So why am I losing half the field? Why am I not getting like the hemianopsia, right? It is because this is hitting the like the Lupomire, right? It's not, you're not losing the whole thing. So you don't get like macular sparing with this. I've never seen that asked as a question, but just like FYI, like it's because you're losing the Lupomire, it like comes through here. And then yeah, just be aware of this phenomenon. Honestly, be aware of this phenomenon. I think the only time I've ever seen this asked on a question, they wanted you to understand that that severe hypotension can cause this. Severe blood loss. It'll say like, what is the patient most at risk for? And it, like, or it'll be like, it'll show you a wedge-shaped like infarct like that, and it will ask what most likely predisposed this person, and it'll be like blood loss, right? Because of the hypovolemia. Stroke management. This is a really big deal. I highly suspect that this will be tested us more years 3. like step 2. This is more step 2. But this is super important. You should know it. And this is another one of those things where if there's a question in the NVMe bank, they're probably going to put it on your exam. You want someone, if we're going to look to treat someone with alteplase, you need to do it within 60 minutes of when you realize that, like, when you're talking to them, basically, right? There's some calculation as to like how much like neural death there is based off of every like 10-minute increments, and like it ramps up, right? Like it becomes exponential. But just be aware that like it's really, really, really important to hit strokes early, which is why we have some of the cutoffs for if it's been so long, there's no point in giving alteplase, you'll do more harm than good. Because of that, I didn't want to like get super into the weeds, so I just put all the drug stuff on like one slide, basically. Dr. Paul, I'm certain, does a much better job running through this than I do. So you would be better off just rewatching whatever his review is before the exam. He'll tell you all the important things, but just the things that you really should like think about going on is you only give know the difference between IV thrombolysis and mechanical thrombectomies, right? And like when we do them, and the contraindications for them. That is the important thing here. So we do not give alteplase to kids. Maybe they do, but for our purposes, you do not give alteplase to kids. You have to be 18 years old. Your symptoms have to have onset less than 4.5 hours ago, and your blood pressure cannot be high. Know the mechanism of action. Know that it converts plasminogen to plasmin, so it breaks down fibrin, right? Alteplase is the one that you pretty much always give. The answer is almost always alteplase. And you can't give it if there is anything that could even remotely predispose the patient to an intracranial bleed. Histories of intracranial bleeds, histories of previous strokes, because then you could weaken the vasculature, right? If they're actively bleeding, obviously. Or if they've had any head trauma, because you might not know that they're bleeding, right? So please, this is the I should have put a star here. Know the contraindications for alteplase. You will get a question. You might get a question that like everything in the question is like, oh, this is textbook. We absolutely have to give them alteplase. Yeah, like, yeah, that's the thing. It says symptoms onset 2 hours ago. They clearly have a stroke, right? They're 18. Their blood pressure is low. Well, not low, but like normal. But then it'll say they have a history of a stroke, or like they were in a car accident last year, sustaining head trauma that has since like had left no neurological deficits. Like they'll start out with that and hope that you forget it by the end of the question stem, right? Know the discreditation. Know what rules somebody out for alteplase. And then mechanical thrombectomy. This is if they do this, they're probably also going to do this. But just know that this is you can do this up to 24 hours out. This is more for DVTs, but if it's bad enough, they'll do it. And then know your antiplatelets. You give these afterwards. You can't give them within the first 24 hours of doing alteplase. You don't want them to bleed. Dual therapy, right? Aspirin, Plavix, right? Everyone knows what we all know what aspirin does, right? COX-1 inhibition. Clopidogrel is the ADP. It inhibits ADP, so the platelets don't activate each other. Clopidogrel is the one they ask about the most. No, be aware of these, but clopidogrel is the one they ask about a lot. And then if you need to reverse, if you messed up and you need to now reverse alteplase, know these two. I've seen tranexamic acid as the answer choice usually. I've actually also seen this, which is why I threw it in here. I kind of thought this was dumb, but I realized I have seen this asked specifically, and I definitely got it wrong because I had no idea. They bind to their lysine analogs. So it's competitive inhibition. They bind to plasminogen and plasmin, and then they can't do their jobs. If someone has a hemorrhagic stroke, the first thing you have to ask yourself is, did we do this? Treat accordingly, if so, right? Heparin, protamine sulfate, definitely know that. Never ever in my entire life have I seen this one asked, mostly because the whole reason we give lower molecular weight heparins is because it's less likely to happen. Warfarin, vitamin K, reverse it, right? It's a vitamin K inhibitor, essentially vitamin K epoxidase, I think. So you give vitamin K, or you can give fresh frozen plasma. I've never seen this as an correct answer choice. Decrease intracranial pressure. Obviously, if they're bleeding in their head, lower the blood pressure in their head. You can do this by Hyperventilation, please remember this, please know this. What you want to do is you want to constrict the blood vessels in the head, so you can make the patient hyperventilate. And then you have osmotic therapy, right? They say hypertonic saline. It's usually mannitol they're talking about, right? It pulls all the water out of your body, increases your urine output, pulls all the water out of your head into the circulating vasculature. And then, of course, they can just crack you open, right? Clipping and endovascular coiling. You don't really know that. Just be aware that these are things. Sometimes you have to do surgery to intervene. I don't think I've ever gotten a question on hemorrhagic stroke, I'm gonna be honest. Certainly not the treatment on it. I've definitely had questions on like they're bleeding because we gave them morphine or they had a bad reaction to heparin, but I've never had a question on it like in the context of a stroke. The limbic system is very complicated. It's very interesting. But unfortunately for anybody who is interested in psych and neuro, it's not really super high yield. The things you need to know that the amygdala is responsible for fear. You have to know that. 150% you need to know that. Amygdala, fear. Yeah, hippocampus, memory processing. I feel like we all know that by now. But Wernicke-Korsakoff syndrome, damage to the mammillary bodies, huge. Absolutely huge. This requires confabulations. Damage to the mammillary bodies, we lose our recall. Because we've lost our recall, our brain starts making stuff up to fill in the gaps. The people with Wernicke-Korsakoff syndrome think they're telling you things that actually happened. But they didn't. Confabulations. Prefrontal cortex, I've seen questions on this too. If you have a damage to the prefrontal cortex, it can just completely destroy your memory. Or not memory, your personality. You'll have like you can develop like a completely different personality. And then I don't know. I remembered the dude's name without looking at the slide, so I was like, I think I remembered his name more than I remembered the disorder, and then like kind of tack things onto him. So whatever. Kluver-Bucy syndrome, I've definitely seen this asked about, right? This is like you have like no inhibitions. You're like being like hypersexual for no reason. Damage to the amygdala. And then you have the Papez circuit for emotion, right? Hippocampus. You might want to know this generally, just this order. Hippocampus to the mammillary bodies, right? So memory to recall memory, to the anterior nucleus, to the cingulate gyrus, right? This is the memory loop. This is responsible for attaching emotions to memory. So this is like heavily involved in like traumatic experiences. Then you have the basal ganglia. This is really important. This is super important. You need to know what this looks like from both views. A lot of times they will ask you a question and they will have basically this diagram with none of the words and just all letters. And when I say all, I mean literally like they'll have like A through I or A through J. And they'll ask you where the damage is or where like the neuron loss is. And they'll do that in the context of like they'll explain Huntington's disease. And they'll have a bunch of arrows. And you'll have to be like, oh, it's in the caudate nucleus. Or they'll explain Wilson's disease. And they'll have a bunch of arrows. And you're like, oh, it's in the lentiform nucleus. You need to know the layout of this because a lot of times you will not be able to answer the question if you don't, and they give it to you from this view, and they give it to you from this view. So know it from both. The ones with stars, super duper know. Parkinson's, substantia nigra, like this should just be a 1-to-1. You should be like if they say Parkinson's disease, you say substantia nigra. If they say Huntington's, you say caudate. If they say Wilson's, you say Putamen. Technically, Huntington's affects both the caudate and the Putamen, but it's kind of like the Dynan-Kinesin thing where whenever they're asking you questions about it, for Huntington's, the answer is caudate, unless caudate is not there, and then striatum is the answer. Super know these. Super duper know these. Subthalamic nucleus, hemibolismus, right? Hemibolismus. One of your arms is just going nuts. You can't stop it, right? Subthalamic nucleus. It is pathognomonic. Like you just 1 for 1. If you see them describing hemibolismus, stop reading the question and look to see if subthalamic nucleus is an answer choice because it 100% is. This is the dopaminergic pathway. So this is the pathway that's messed up in like things like Parkinson's, right? Partially. This is like kind of what's like affected downstream. A lot of the drugs that we use to like work on this. The important thing to know, the super important thing to know is what's printed here. This ultimately, there's two pathways, right? You have the D1, which is the direct pathway, and you have the D2, which is the you have the D1, which is the direct pathway, and you have the D2, which is the indirect pathway, right? The globus pallidus interna is the common endpoint for both of those pathways. It is inhibitory on the thalamus. It is inhibitory for movement. The GPI is inhibitory for movement. So D1 stimulates the striatum to inhibit the GPI. Because you're inhibiting the inhibitory center, you're increasing movement, right? So the direct pathway facilitates movement. Sometimes they will ask the question, and instead of the answer being stimulating movement, the answer will be inhibiting the globus pallidus interna, GPI, right? The indirect pathway goes through the externa and then the subthalamic nuclei, and it stimulates the GPI, which means it inhibits movement. Indirect, inhibitory. It stimulates the GPI, but the GPI inhibits movement. Very important to know this. Very important to know this. And then the inputs from the substantia nigra pars compacta, which is why in Parkinson's you lose this, right? Which means this whole system's messed up. Know that glutamate is the excitatory neurotransmitter here, and that GABA is the inhibitory neurotransmitter here. Yeah, I hope you know that by this point, but definitely know that, because sometimes you'll see like they'll talk about, I don't know, if you increased glutamate in the GPI, what would happen basically, right? And you would get a decrease in movement. But seriously, super duper. If you only remember three things from this, it's that this is inhibitory to movement. D1 inhibits this, which makes it pro-movement. D2 stimulates this, which makes it anti-movement. Please know that. Please know that. Please. That's all. You don't need to get super into the weeds on anything else. Know that. We have it listed as ABC. Some people like mnemonics like this, right? Action, behavior, cognition. This isn't super useful to me, but this is a nice summary of everything that it does. If you forget for some reason, I don't know. I got nothing. Parkinson's disease, unbelievably high yield, stupidly high yield. You need to, in questions, see the words shuffling gait and mask-like face and immediately think Parkinson's disease. If you read shuffling gait and mask-like face in a question stem and you do not immediately think Parkinson's disease, splash yourself in the face with cold water until it sticks. Because you can because a lot of these diseases present the same way. You need to know the words they use to give it away to you. Mask-like face basically means they don't have their all their facial muscles go limp. So they just like have absolutely no emotion whatsoever or expression on their face. Like it looks like they're wearing like a Halloween mask, right? Like because like they do not have the capability to give facial expressions. They're just. But this is so, if they use these terms specifically, they are telling you that at the very least, the person has Parkinsonian symptoms. So you should immediately think Parkinson's disease. And the reason they have the shuffling gait is so they don't trip, because the deficiency in dopamine causes a foot drop. And if they lift their feet all the way up the ground, they'll trip over their own toes. You should know all the other things, obviously. God, please know that loss of dopaminergic neurons in the substantia nigra pars compacta, you can physically see it, right? They get lighter because the dopaminergic neurons are dark. I answered questions off of this picture alone. Know this. In neuro, you really need to know the imaging. You need to know the imaging. You need to know the histo. It helps so much. Could you answer all the questions without it? Yeah, mask-like face is the same as flat affect. The only difference is if they say flat affect, they could be talking about like psych disorders. Granted, Parkinson's causes depression, but so does Wilson's disease and Huntington's disease. Mask-like face is only used in the context of Parkinson's disease. I have never seen the word mask-like face used outside of Parkinson's disease. But yes, it is the same as flat effect. Yeah. But yeah, so no, there's no trap. The pill rolling tremor, they just sit there and do this with their hands. I don't know why. Maybe it makes them feel better. I don't know. If they're doing it and you point out that they're doing it, they'll stop. So it's a weird thing. Cogwheel rigidity and lead pipe rigidity, right? It's not like the clasp knife rigidity where like you pull and it releases. You pull against it and they can hold it for a little bit and then they can hold it for a little bit, and it's because the basal ganglia loop, right, is like cutting in and out essentially, right? Know this. Decreased serotonin and norepinephrine in the Raffi nuclei. Know this. No Raffi nuclei. I should have put a star here also. Sorry, I'm failing you guys today. I've definitely seen questions in a lot of contexts know that decreased serotonin and norepinephrine in the Raffi nuclei causes depression. Conversely, too much activity in the Raffi nuclei can cause anxiety, but that should just make sense. And then this is like your if they ask you what you're going to see in this patient, alpha-synuclein, which is like your Lewy bodies, right? Not to be confused with Lewy body dementia, but you do technically get Lewy bodies. You get accumulation of alpha-synuclein in Parkinson's disease, which are these. Not that, but definitely this one, right? And then, like I said, loss of pigmentation of the substantia nigra. Super high yield. And then this is what I was talking about. So Parkinsonianism. Everybody knows. Well, I shouldn't say that. Most people associate Parkinson's with decreased dopamine, but what is important to know is that it's not just low levels of dopamine. It is a disproportionate balance of acetylcholine and dopamine. So increasing acetylcholine can also have more or less the same effects as decreasing dopamine in a lot of cases. And when we talk about the drugs and some of the like kind of when you look at like some of the adjacent disorders, this makes it make a lot of sense. But it's important to know, it's important to think and internalize to yourselves that it is not just a decrease of dopamine. It is the ratio of dopamine and acetylcholine that is off. And this is really highest yield for pharm, because if you kick the ratio, if someone has Parkinson's and you have high acetylcholine and low dopamine in retrospect to each other, or in perspective of each other, and then you correct it medically and flip it, you're going to cause psychosis. This is also why a lot of the antipsychotic drugs cause Parkinsonianism. The ratio is just as important as the decrease in dopamine. Very, very, very important. Yeah, like I said, antipsychotic drugs. And then if you damage if you damage the substantia nigra, it doesn't send dopamine to the basal ganglia, right? So then you get Parkinsonianism. If you damage the basal ganglia, well, obviously it just doesn't work, right? So then you get Parkinsonianism. Yeah. Huntington's disease. Oh, okay. So I probably have Huntington's and then Wilson. So it isn't here. Okay. Loss of GABAergic neurons in the striatum. Caudate and putamen. Caudate is the one they usually ask about. It is a CAG triplet repeat expansion. Like I said, these triplets, know them all, know what they do. They are very important. They ask about them constantly. It will be the answer choice that you select. You can remember this. There's like a little mnemonic with it, but you have too much dopamine and you lose GABA and acetylcholine. So this messes up that dopamine acetylcholine axis we were just talking about, and you lose inhibition, right? Because you lose GABA. And the little mnemonic here is CAG. Caudate loses acetylcholine and GABA. If you remember that, then you should remember that like if acetylcholine's low, dopamine's like high, right? Another thing that's kind of weird, but this is more of like an AMBOSS fact, is it's a toxic gain of function mutation. The reason being is that this gene that it's in is apparently a pro-apoptotic gene. But as somebody with a background in genetics, I don't really agree that this is a gain of function mutation, because from what I can tell, and I read research articles on this to try to figure this stupid thing out, this is like an unfolded protein response, which is not quite pro-apoptotic. But the point is this Huntington gene is a pro-survival gene. It is a anti-apoptotic gene. So when you get a bunch of expansion repeats in it, you just lose it, right? Anticipation. Know what anticipation is. Because I accumulate CAG repeats and then I pass them all on to my kid, and now my kid accumulates more CAG repeats and passes them all on to his kid. With each generation, it gets worse and worse, which is why a lot of times in these questions, you will see a stem that like will describe like Huntington light symptoms in like the dad in like 50 years old. And then the guy will be presenting in like his mid to late 20s, with the same symptoms or worse symptoms, right? This is really important. I don't think this gets harped on enough. If you overstimulate neurons with too much glutamate, they'll just die. The MDA receptor will cause the neurons to basically die, which is how you get this degeneration. And then here, like I said, 30s to 50s. A lot of times the symptom that will really like give it away is aggression. The person will become aggressive. And then suicide risk is really high. Suicide risk is really high because the disease process itself makes them very depressed. This disease is essentially a death sentence, but that's not why the suicide risk increased. The disease itself causes depression, dementia, mental issues, and then eventually they will die due to respiratory depression. So they'll get like pneumonia, aspiration pneumonia, and they'll die due to respiratory failure. The other thing too, I've definitely seen this in question stems, because it presents with strangely in the beginning, and they're usually aggressive and depressed. This can be easily mistaken for substance abuse. And considering your exam covers both this and substance abuse, it's just important to keep that in the back of your head. But this is also one where they will give you Huntington's disease. You will sit there and you will be like, oh, this is Huntington's. And then they'll point with a bunch of arrows and be like, where would you expect to see degeneration of neurons? So you need to know it's in the caudate or the putamen. Usually the caudate, but if they ask you to point and they're both options, put caudate. But just be aware that it could technically be both, because those are both part of the shebang. Symptoms chorea. This is the weird dancing that kids do when they have rheumatic fever. It's part of Jones criteria. It is the S in Jones criteria. Don't forget that rheumatic fever exists. It used to be stupid high yield, and if you look at any of the forms pre-form 20, rheumatic fever is on there a bunch. Not really tested so much anymore because it's universally understood to be really important. They just expect you to know it, right? But please know Jones criteria just in general moving forward, especially since you guys are going to be taking comp in like 2 months. Not to scare you, but and yeah, know that this also affects the caudate nucleus. Just be aware of this. I've never seen a question on this, but it was in their slides, so it's just a good quick reminder. Wilson, I knew I had it. Okay, you guys want to see the stupidest thing in the whole world? Wilson's disease is on chromosome 13. And sometimes you're being silly with your friends and you're trying to think of new medicine mnemonics. Wilson Sporting Goods Company was founded in 1913. I didn't know that. You didn't know that. Nobody knows that. But you're going to know that now because it's stupid. How stupid is that? Wilson's disease, chromosome 13. Wilson Sporting Goods store, founded in 1913. How stupid. I hope you guys remember. I hope you guys get a question out of this. I thought that was ridiculous when we jokingly said this and it turned out to be true. What are the chances? What? How many billions of years since the Earth's been formed, or million? Like it's so stupid. It's so stupid. But maybe you'll remember it now. Do know for sure this though. ATP7B genes, super high yield. Asked about all the time. So often. Either they'll just tell you there's a mutation in this, and they'll want you to know the person's going to get Wilson's disease, or they'll explain Wilson's disease, and the person has this. This, I would say, was maybe the most asked about one out of all of them, which doesn't make sense to me. You would think Huntington's would be asked about more, but this is definitely, I've seen this on tests way more than I've seen Huntington's on tests. The problem is you have defective copper transport. You can't get it out of your cells. It gets in but can't get out. And it's neurotoxic for your dopaminergic neurons. I think earlier I said motor neurons, dopaminergic neurons, which means it affects specifically your basal ganglia, right? Yeah. Hepatitis, right, accumulates in the liver, right? So you'll have liver issues. And if you see anything that's like combining liver issues and also like ataxia, it's probably Wilson's disease. This is the Keidler-Fisher rings, or like the calf rings. They get like these golden rings around their irises. I've seen literally just this picture or some very similar picture on the exam before and just immediately knew it was Wilson's disease. And if you remember when I was talking about the eye problems and like the retina problems, the diagnosis for this is slit lamp uh, test. So they'll have decreased serum ceruloplasmin because it's all bound to the copper, and they will have increased serum and urine copper. That should make perfect sense to you. The problem is your body has too much copper. Like you have too much copper. Yeah. Treatment, low copper diet. I didn't know that's a thing. Does anybody here know a single food that has copper in it? I sure don't. I'm gonna guess carrots because they're red and they come from the ground. Maybe beets. I don't know. And then you treat with chelating agents. Know this for sure. Penicillamine, 110% know this. They're not going to ask you either of these. The answer will be penicillamine. If they're going to talking about Wilson's disease, you treat it with penicillamine. Hemibilismus. If I didn't make it clear enough earlier, the only thing you need to know, hemibilismus, subthalamic nucleus. Extrapyramidal reactions to antipsychotics is what I was talking about, how antipsychotic drugs can cause some of these symptoms. The really big one is tardive dyskinesia. So akathisia is just like you can't sit still. So you're fidgeting, right? Like they keep crossing their legs, whatever. Rabbit syndrome is like acutely within starting antipsychotic drugs, you start to have these like hyperactive syndromes. But the key here is rabbit syndrome happens soon, weeks after starting antipsychotic drugs, and the symptoms resolve when you stop. Tardive dyskinesia, which is what you'll probably be asked a question about, this happens after years of taking antipsychotic drugs. This does not get better when you stop them. I think in his slides, it said it did. This does not. This does not get better. And if it does, it doesn't completely go away. Rabbit syndrome, quick, right? Quick like a rabbit, quick onset, resolves. Tardive dyskinesia takes a while to build up, does not resolve. And the big giveaway here is it's this tongue protrusion. Well, the like it's I've heard it called before, like there's a thing called like a lip smacking tremor, and they'll like smack their lips and then like stick out their tongue and put it up, and they don't realize that they're doing it. That's another big thing. Like they're not aware that they're doing this. Haloperidol is a big one for this. Yeah, but yeah, the biggest thing is differentiating these two. This takes a while and doesn't go away. This is quick and does go away. Also, if you give Parkinson drugs, it actually worsens it. Because so I don't know if I had this. I meant to put this in here in one of these. So like Huntington's, for example, you're losing cells, right? Maybe this is a bad example. Yeah, I guess not Huntington's, but Parkinson's. In Parkinson's, you have less dopamine, right? So your body upregulates the receptors. So you initially have, even though you have lower levels of dopamine, you don't have any symptoms because you have more receptors. This is kind of like the same deal, right? As we knock out the dopamine receptors, our cells become hyper sensitized to dopamine. So giving any like the Parkinsonian treatment drugs will make this worse because their body's hypersensitized to it. For Parkinson's drugs, Dr. Paul is the best, but they ask about these a lot. The really big thing to know is the whole levodopa carbidopa dynamic. You give dopamine agonists, right? And then another way. So if you don't want to give, right? So this is give more dopamine, right? These increase the half-life of dopamine. Monoamine oxidase B is specific for dopamine. This is not the same as the monoamine oxidase inhibitors you use to treat depression. It's not the same. This is more specific. COMT, same deal. Increases the half-life by preventing the breakdown. So if and this is where it kind of gets in the weeds a little bit. If the problem that's causing the Parkinsonianism is due to decreased dopamine, the answer is to increase dopamine. But if you remember, what I talked about was the balance is important. So if you have too much acetylcholine, you can give anticholinergics to help treat the symptoms. And this is important in someone with like a history of like bipolar disorder, right? Like you can't give these drugs to someone with, or at least you really shouldn't give someone these drugs with bipolar disorder, right? Like it'd be a wildly high risk to anybody that's like predisposed to mania or psychosis to start giving them dopamine, right? So you treat it in the other direction and you knock down the acetylcholine. Also, sometimes we give them these and we cause this, so then you give them these also. I don't know what this. I'll be honest. I don't know what they mean by this. I don't know any neuroprotective agents off the top of my head. Know this for sure. Know these for sure, and then know this thing I just talked about. And here he talks about, right. So your cholinergics, ibentroxapine and trihendenadil, right? They sound really weird, which is how I remember them on the exams. Your COMT inhibitors, and then Capone. I always remembered these by right. Al Capone was like a mobster in Chicago. He was taken down by the IRS, right? The IRS is a bunch of crooks, a bunch of government crooks, right? Taking your money and redistributing it. Al Capone was brought down by the commies, the COMTs, right? So I remember that. And if anybody knows what a MAOB is, it stands for like in slang like mother of all bombs, right? So Jaline, you have to keep in line before you drop your MAOB. I don't know, man. I think it's stupid things to remember stuff sometimes. But these are, you add these on if this management is not working well enough. You can add these on. And usually the question, if they're asking about either of these, it'll talk about how the patient's on levodopa, carbidopa, and like what do you reach for next, basically. And then it'll be either one of these. I believe you go MAOB first and then COMT, because these are neuroprotective. But it is what it is. I've also definitely seen know that chalcopone is hepatotoxic for sure. For this module, all of the drugs that are hepatotoxic, know those, and all the drugs that are CYP inhibitors and inducers, know those. You will 100% have a question on the CYP drugs. Yep. Prampexanol is the one that usually gets asked about for the dopamine agonist. But this is the really important thing, and I have a whole slide on this, so I'm going to talk about this in the next slide, right? So when you give dopamine to somebody, dopamine cannot cross the blood-brain barrier, right? So we give levodopa. Levodopa is a precursor to dopamine. The problem is, and that can cross the blood-brain barrier. The problem is levodopa breaks down peripherally to dopamine. So you end up with a bunch of side effects because when you give levodopa, you are increasing dopamine in your body more than you're increasing it in the brain, right? Because yeah, some's crossing the blood-brain barrier, but it's such a small amount of the total volume. So the solution to that is you give carbidopa. Carbidopa inhibits dopa decarboxylase and prevents levodopa from breaking down into dopamine. But carbidopa cannot cross the blood-brain barrier. So you're giving two drugs that can't cross the blood-brain barrier. Or you can't give dopamine, right? So dopamine can't cross the blood-brain barrier. So you're making more dopamine, but you're preventing it from accumulating peripherally because carbidopa can't cross the blood-brain barrier. So it's only inhibiting peripheral conversion of levodopa to dopamine. It does not affect the dopa decarboxylase that's on the north side of the blood-brain barrier because it can't cross the blood-brain barrier. So this helps you more specifically increase the amount of dopamine in the brain. This is standard of treatment. This is super important to know. These are the three biggest side effects. There's more side effects, but nausea, vomiting, orthostatic hypotension. Orthostatic hypotension very specifically is due to like this increase in dopamine. Yeah. Yep. All right. For the drugs, of abuse and addiction, just learn what the drugs do. If you know the mechanism of action of all these drugs, and you know vaguely what they do to a person, withdrawals are the opposite. Like, it's as easy as that. It's as simple as that. If you if you're kind of sheltered and you don't know what all the street drugs do, you're gonna have to just learn what they do and then do the opposite for withdrawals. But if you are even a little bit socially pop culturally aware, you'll be able to answer all these questions. Like, oh, it sounds like this person's on coke. It sounds like this person's on PCP. There are a couple things they ask about a lot that I'll point out, but I just thought this was a good summary. I like this slide a lot. You don't need to memorize everything on here. Generally know what these drugs do. I stole this right from Dirty Med. Just so you guys have right in one spot. This is all of them. This is all the mechanisms you pretty much know of drugs of abuse for the for step 1 for your in-house exams. Here it is in one spot. Okay, so here's another one. Here's like another way it's organized in more of like a table form. The reason I gave you guys these 3 because like I don't want you guys to have to go like dig through resources to find stuff. Like everything you need to know should be somewhere in these 3 things. But they always ask you about the same things, right? So for opioids, you need to know that in opioids, in an overdose, there's going to be severe respiratory depression, right? That's usually what kills the person. You have what naltrexone, right? Where you reverse it. The other thing too, the eyes. The eyes are dead giveaways for a lot of these questions, specifically in overdoses, right? Opioids, pinpoint pupils. Cocaine, PCP, huge pupils, right? Benzos and barbs, if they're asking about this in the realm of drugs of abuse, either they're talking about the ceiling effect, and it's like benzos versus barbs, right? Ceiling effect, barbs cause infinite respiratory depression, benzos like there's a limit, or their compound effect with alcohol, or because alcohol also works with GABA, you can use these to treat alcohol withdrawals, right? Which for your purposes is you need to be able to distinguish, like they gave you like 5 different levels of alcohol drunkenness and withdrawals, but the only one that really matters is delirium tremens, which is the last one, which we'll talk about. PCP, you need to distinguish the 2 of these from each other in a lot of stems, and they are almost identical, except PCP causes a nystagmus, cocaine doesn't. They'll both make you aggressive. You can hallucinate on both of them. They both make you amped up. They'll both dilate your pupils. PCP has a nystagmus. Cocaine does not. It's a big deal. I've seen a lot of questions, right? I don't know about you guys, but when someone's on cocaine, the last thing that I'm thinking about is that they're seeing things crawling on the walls. But they love to say that people on cocaine are having visual hallucinations, but then they'll tell you and fighting people. So many times in these questions, they're fighting people. But there's no nystagmus. Nystagmus, PCP. No nystagmus, cocaine. I was supposed to put this on one of your older slides, but I didn't. I was like, I'll throw it in here. Why not? Listen, man, these questions are free points. If you don't get this question right, I don't know that any of this tutoring is going to help like you answer these questions. Look for the signs exactly. Treat old people like they're infants. If somebody is old enough and incapable of caring for themselves to the point where they need a caregiver or they are in a home, for all intents and purposes, they should be treated like infants across the board. So physical abuse, it's all the same things. Bruises in places that like they couldn't bruise themselves, right? So like the inside of the arms, the side of the torso, under the arms because they're being like lifted up, on the wrist because they're being held down, bruising around the mouth because they're being force fed. Any signs of like them pulling against restraints. Spiral fractures, it's basically impossible for an old person to do something that would give themselves a spinal fracture if they're in a care setting. So I think what's more important than these, because it should be really obvious. Neglect is also maybe, I guess the one thing here is neglect is the most common like form of elder abuse, which might not seem completely obvious, but usually it's, your poor hygiene and they haven't been taking their meds. This is the more important thing is if they have dementia, if they're from a low income, and they can't financially take care of themselves and they're dependent on others, it puts them at risk for elder abuse. Also, if they only have one caregiver, the caregiver is more likely to abuse them. Okay, so alcohol withdrawals. Like I said, I'm not including any of the other withdrawals because if you know what the overdose symptoms are, you also know what the withdrawal symptoms are. I have used that extensively to answer every question. I don't think I've ever missed a question unless I just didn't read it properly. I promise you can answer all the questions just based off knowing what the overdose symptoms are. You can answer the withdrawal symptoms. But know the timeline for this, because what can happen, what they'll do sometimes is they'll talk about a patient and they'll be in the hospital and it won't be really clear that they're drinking, right? Usually it'll be found unconscious on the sidewalk, brought into the hospital. If it has been more than 24 hours, it is probably alcohol withdrawal. If it's been more than 24 hours, it is probably alcohol withdrawal. Treat it with barbiturates. And then no delirium tremens. There's not very many withdrawals that will actually kill you. Alcohol withdrawal will actually kill you. Not like the things that happen because of withdrawing lead to you dying. No, alcohol withdrawal itself will kill somebody. So no, you need to know these, the DT signs. This says 48 hours. Yeah, that's right. Like 2 to 3 days for DTs to really set in. The confusion, agitation, fever, tachycardia, hallucination, right? Know this. Yeah. Also know this too, I guess. You don't need to just because they're hallucinating, it could be if it's clear they're withdrawing on alcohol, but hallucinations alone don't make it delirium tremens. They need to be like sick, and it has to have been at least 48 hours for them to consider it DTs. If they're hallucinating but their vitals are stable, it's not DTs. They have to be in rough shape. But this is timing. The timing is the important thing here. Yeah, 2 to 7 days, 5%, blah, 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 right? %20 mortality rate by the time you reach it. And then the other big thing too, alcoholics, Wernicke-Korsakoff syndrome, thiamine deficiency, also known as beriberi. Don't forget wet versus dry. The only real difference between wet and dry beriberi is cardiac involvement. It's just like macular degeneration. Wet means like cardiovascular systems involved. Dry means it's not, right? Wet versus dry beriberi. Yeah. I think this has been beaten to death in at least 3 semesters, so you guys should know this. Remember, it's the mammillary bodies, super duper high yield, stupidly high yield, unbelievably high yield. I guess the only other one thing I'll add here is Wernicke's encephalopathy is like all of the symptoms that would probably bring somebody into the hospital. Like they're off, they can't walk, they're falling over, right? They're really confused. Once they have confabulations, it becomes Wernicke-Korsakoff syndrome. In most of the stems, if amnesia exists, confabulation will also exist. But confabulation is like is the threshold for them a lot of times, which is what makes it Korsakoff syndrome, not just Wernicke-Korsakoff syndrome. Again, I don't think they're gonna really dig in on that, but please God know that it destroys the mammillary bodies. Also, this actually, I didn't really think about this until just a second. This is actually a good point too. The reason why this actually happens isn't like the other problems with alcohol where it's like messing up metabolic processes. They just stop. It's a malnutrition because you can't eat properly if you're just full of alcohol all the time, right? Or if it's just like going through your system, or if you're just vomiting it. So it is a malabsorption issue. But no, this is super duper high yield. Wernicke-Korsakoff is wildly high yield. Fetal alcohol syndrome. Personally, I thought this was Fragile X, but maybe Fragile X is the most common genetic, inherited intellectual disability. But my mom's a special needs teacher, and a lot of her kids have fetal alcohol syndrome, so I believe this. But yeah, a lot of times when they give this away, thin upper lip, smooth philtrum, fetal alcohol syndrome. right? Microcephaly, craniofacial malformations. There's a lot. Short adult stature. A lot of different diseases have this. But smooth philtrum and thin upper lip, that is the only thing I can think of that causes fetal alcohol syndrome. Disulfiram. This is really important. Please remember, disulfiram inhibits aldehyde dehydrogenase. Disulfiram does not inhibit alcohol dehydrogenase. Does anybody know what fomepizole is used for? Which does inhibit alcohol dehydrogenase. I know y'all learned this. Maybe you learned it in MTM. Nobody knows what. Come on now, you're getting in the territory where someone's Googling it. It's an alcohol dehydrogenase inhibitor. What else does alcohol dehydrogenase do? Can you get another hint? It fixes a poisoning. You're probably more likely to give it to a dog than a person, I guess. You need to know this for not for that. You need to know this for comp though, for sure. All right. Ethylene glycol poisoning. Antifreeze. So alcohol dehydrogenase breaks down alcohol into acetaldehyde, but alcohol dehydrogenase also breaks down ethylene glycol, which is the toxin in antifreeze, into its toxic components. So you treat antifreeze poisoning with alcohol dehydrogenase inhibitors. What you can also do is you can just get them drunk. If somebody drinks a bunch of antifreeze and you shove a fifth of vodka down their throat, all the alcohol dehydrogenase will be preoccupied breaking down the alcohol, and it will not be able to break down the ethylene glycol. So I don't know, if you're up north and your friend's real depressed and it's a blizzard and you're stuck in a cabin and they drank a bunch of antifreeze, force feed them vodka, right? But it is important. It's important to know disulfiram. It's important to know that disulfiram inhibits alcohol dehydrogenase, or I said it again. Disulfiram inhibits aldehyde dehydrogenase, and fomepizole inhibits alcohol dehydrogenase. And this is very important because I've never, ever, ever seen a single question that asked about this in either direction that didn't have both of these as answers. Every time they ask about this, both of these will be answered. Alcohol dehydrogenase inhibitor and aldehyde dehydrogenase inhibitor will both be answers. They're not going to look for you to say disulfiram or fomepizole. They're going to ask you to say alcohol dehydrogenase inhibitor or aldehyde dehydrogenase inhibitor, or they might ask for the accumulation of acetaldehyde. So it's really important not to mix these up. Yeah. Also, just like a quick note, if you've ever heard of like the other drugs, like specifically like antibiotics that cause like a disulfiram-like reaction and they make you like super nauseous, this is why. This is where it comes from, right? Yeah, right. You need to know this. Sorry, you just got to know it. I've seen a bunch of questions on this. Every form has a question on this. Know this. Dirty Med has a good video on this. I recommend you watch it. And then don't forget Cage, right? You'll probably have a question on this, right? They have to, because the school has a policy of every OLM gets a certain number of questions. There's only so many things they can pull from some of those OLMs. So you're probably going to be asked about Cage. You're definitely going to be asked about this. And a lot of times it'll be like a patient is just talking about like, oh, well, you know, I thought about quitting, but I'm just not ready, right? And that's right, like contemplation, right? Or like if somebody says, I think I need to lose weight, I'm gonna go get a gym membership and I'm gonna do this, I'm gonna do that. That's still contemplation. preparation, they've like done things more than just thinking about what they need to do. They might not be like going to the gym yet, but they at least got like a membership. Watch Dirty Med's video on this. It's really good. It's like if you double speed it, it can't be more than 5 minutes long. And then of course you guys know Cage. All right, so I have a bunch of practice questions for y'all. You know the drill. I'll give you like a minute per question. Does anybody, before we start these, does anybody have any questions from today or from Tuesday? Like questions about anything that you want me to like run through again real quick, or just talk about? All right. Nope. Okay, we're gonna go on then. If you do think of like a question you want to ask me, you can also message, and you don't want to like post it here. You can message me on WhatsApp, and I'll just talk about it to everybody. So feel free. Please don't hesitate. All right. Does anyone know what drug they're talking about here? Although it's okay if you guys don't know these like drugs of abuse questions right now, but I want you guys to see the way that they ask these questions, because there's not a good way to there's not a good way to like specifically study for these kinds of questions. You have to kind of just see the kinds of things that I think it's more beneficial to see the questions before like really doing like studying on this kind of thing. I guess I don't know how else to say it, because like I said, they ask weird things. But what drug is this, first of all? Your hint on this question is local anesthetic. It is cocaine. That's correct. So what does cocaine do? Same mechanism of action as Wellbutrin, mostly. Yeah. It decreases the synaptic reuptake of norepinephrine, right? Yeah. Yeah. Local anesthetic was like your oh, it's cocaine. But euphoria and pupillary dilation, when you see this, you should be thinking either PCP or cocaine, right? And like PCP works on like NMDA reactors, and I don't see NMDA react well, right? Like so cocaine. Yep, that's correct. Spasticity. All right, upper motor neuron loss, Babinski reflex, spastic. Yep, that's correct. Right. This is nonsensical phrases. Can't repeat single words. This is word salad, right? Also, right-sided body weakness. That means the lesions in the left side of the head. That is classically where Wernicke's and Broca's regions are, right? Wernicke aphasia, MCA lesion. All very high yield things. It is B. What's wrong with her? This is important. This distinction is important. Yep, she's BPV, right? And in BPV, we get a nystagmus. Our ears think our head is moving even though it's not, and our eyes try to stay centered, right? BPV. Maybe this was a little mean, right? Because we did cerebellum today. But we definitely went over this previously, and I don't want you guys to fall into the trap of just picking answers that we talked about today specifically. And like I said, it's important. It's important to be able to make these distinctions. Yeah. F. Well, I mean, you're on the right track, right? So where is this at, right? Where it says left precentral gyrus, right? So it says left precentral gyrus. So you know that it has to be a motor problem on the right side, right? So you can rule out. I mean, this, yeah, rule this out, right? Rule this out. If this said right ear, E could be correct, right? But it says left ear, so no go. Inability to raise the right eyebrow. Is the facial nerve responsible for that? It's not really, right? So it is B. Oh, I promise it's B. It's B. It's B. Because you're gonna have left precentral gyrus travels through the internal capsule. They're kind enough to tell you it's going right to the facial nerve. Facial nerve is responsible for these muscles. Contralateral side, it is 100% B. This is a big sign for like stroke and like distinguishing between like Bell's palsy and stroke, flattening of the nasolabial fold. Sorry, I promise it's B. You just gotta take my word for it. I must have not put the slide in there. We must have accidentally copied this one over to something. Yep. What's wrong with the person? Wilson's disease. What chromosome is it on? 13. Yeah, you guys are right. Yep, it's Wilson's disease. If you see 28-year-old, it's probably Wilson's disease. I'm just gonna be really honest. If you see someone under the age of 30, it's probably Wilson's disease. Or it's got to be either Wilson's disease or Huntington's disease. And if it's Huntington's disease, they're going to tell you that it happened in one of their parents in like when they're like 40. Also, quick note on this too. I said it, but I think I said it to myself. I don't know if I said this out loud. Why is this not correct? Like actually, right? Because this is not a bad answer. It's not a bad answer. Yeah, right. Right, that's correct. So remember the difference between Bell's palsy and a cortical stroke is that in Bell's palsy, you lose the whole side of the face, whereas in a cortical stroke, you only lose the bottom side of the face because both the left and the right motor cortex innervate the top of the face. And only the contralateral side innervates the bottom of the face, right? So that is why this is not correct, is because they want you to say they tell you that there's an infarct. Straight up tell you there's an infarct. So you know it's not Bell's palsy. And I said the thing about Bell's palsy, but I didn't really like explain that. I didn't want like to just like gloss over that because this is very important. It's very important, and this is again they're sneaky about it, right? They were very sneaky about it in this question, and they can ask it the other way around, right? Where like patient has if they tell you they have an inability to raise the right eyebrow, well then you know it's Bell's palsy, right? And you can say instead of you know a stroke, the answer will be nerve involvement, right? It could technically be like a lesion in the brainstem itself, but you get what I'm saying. The point is it's not a stroke. Oh, okay. So I inserted them in the middle of the question. I see what I did. Yeah, I see. I see what I did. Yep. What's wrong with the person? Yep. What region is this? Perfect. Yep. And they gave you shuffling gait, right? So you know what Parkinson's, right? Substantia nigra. Loss of dopaminergic neurons, which are darker than the cyan nerves. It is D. What's wrong with the patient? It is Huntington's. Yep. So this is a bit of a weird question because I'm gonna be really honest with you. If this sentence wasn't here, I might get this question wrong. Like I this isn't like a super straightforward question. I could reason my way that if this is because of this type of ataxia she has, it's probably some type of dopamine disturbance, right? But this isn't very clear that it's Huntington's, right? But the thing is, right, 38 years old. If you see 38 years old, you go less than 40, it can only be one of a couple things, right? So you got to be thinking Huntington's. But yeah, that's what I was saying. Like they're super this um this they want you to know, and this they want you to know she's really depressed. That's why they said this, which also kind of clues you into Huntington's, right? Yes, it is heroin. Why is it heroin? Because it sounds like they have the worst flu they've ever had and they feel like they're going to die. Um, Opioid withdrawals are like the worst flu you've ever seen in your life. That's how I think of them. Um, right. This, I'll be honest, I don't know. I don't know what pupils normally are. Is this big? Is this small? I don't know. Um, but if they're going through opioid withdrawals and doing opiates gives you pinpoint pupils, I would have to guess this is probably a little big, right? Bowel sounds are hyperactive. Opioids are notorious for slowing down your gut. Reflexes are brisk, right? So it's not going to be a stimulant, right? Barbiturates and alcohol. Okay, I mean, I'm listening, right? Like maybe. But is there anything in the stem that would like be able to distinguish between these, even if either one of these was the right answer? No. It's heroin. It's an opioid. You're looking for opioids. So this would have been the same thing with like Norco, right? Like in narcotics or something. I apologize if the picture's a little hard to read, but there was really no way for me to blow it up and put it like on the same thing for y'all. And also, you've seen this picture enough. You should know. Mm. It is cocaine. It is no reuptake. But what letter is the MAT? Right? Because like G is a receptor, right? So it's not G. No. Okay. I'm gonna give you the benefit of the doubt, and so you just can't read this. This is the acetylcholine receptor. It is F. F is the MAT channel. I mean, you know, right? You got it right. You knew it was cocaine. You knew it was reuptake, right? Here it is blown up, right? Like there's just no way for me to do this like really on the previous slide, right? So cocaine stops reuptake, right? Uh, norepinephrine, dopamine, and serotonin, right? This is Wellbutrin and amphetamines, except amphetamines also increase release, right? But yeah. See. Yep. Let's see. This is just Parkinson's, right? This is what I was saying. Alpha synuclein, they love to talk about this. When you guys get, yeah, you should have gone over it by now, but I know you haven't because I've been going over everything. Lewy body dementia is the other thing that's like uh, alpha synuclein, right? They cause Lewy bodies. Know what this looks like on histo. I know I showed you the picture where it's like the big ball in like the middle of the cell. So like with these, I don't know, maybe this is pointless, but I'm gonna try it anyways. For Lewy bodies, you're going to have that like big thing is the Lewy body. Um, you'll see like a lot of like granulations around. That isn't the Lewy body. I always thought those were the Lewy bodies. I always got that wrong, but it's the big thing. It's not the granulations. The granulations is like an artifact of the staining. Um, Hmm. What's the disease? Is- Why do you think it's Niemann-Pick disease? Because I talked about it today? It's not Niemann-Pick disease. It's Tay-Sachs, and I did this to prove a point. This stem does not tell you that there's hepatosplenomegaly. So if you see a stem that does not tell you the patient has hepatosplenomegaly, you better be real sure that it's Niemann-Pick disease, and Tay-Sachs better not be an answer, because that is the only time in a question stem that I am ever putting Niemann-Pick disease as an answer choice. If both of these are options, is if it tells me that they have hepatosplenomegaly somewhere, right? Because all these other things are the same. The only thing here that really tells you it's Tay-Sachs is this startled by loud noises thing. That's Tay-Sachs, right? Like that's pathognomonic for Tay-Sachs. But the point is, and I, honestly, right, abdominal exam shows no abnormalities, right? It's Tay-Sachs. It's Tay-Sachs. Very important distinction. So whatever. Maybe I was being a little bit of a dick, but I did mention that Niemann-Pick disease is always going to be talked about if they're trying to make you distinguish between Tay-Sachs. And I certainly mentioned the hepatosplenomegaly thing. So think about this. Remember this moving forward. That's probably going to get you guys a question in the future, like guaranteed. Yep, that's correct. Even been so. This is what I was talking about, right? Advanced stage liver disease. Been in the hospital for a couple of days. Not gonna be able to drink while he's in the hospital, right? So he's gonna have withdrawals, right? Acute withdrawals of the benzo. But this is how they will tell you in question stems that um this is how they will tell you that you're supposed to be thinking this person's an alcohol withdrawals. Is they probably have a history of drinking alcohol and they've been in the hospital for a few days, right? Uncomplicated knee replacement, right? So he's just been in the hospital like for recovery, but he hasn't been able to drink. You have to, a lot of times, you have to infer that the patient is an alcoholic. They will not straight up tell you. That is the COMT one, right? That's correct. Why? Why is it not carbidopa? Because carbidopa inhibits dopa decarboxylase. Dopa decarboxylase. Entacapone is a COMT inhibitor. Entacapone, right? COMT. The T, I'm pretty sure is, I think this is methyltransferase, right? I'm assuming this is CO methyltransferase, right? Yeah, this is just a mechanism of action question. But right, bait answer, obviously a trap answer. Also, right, what do these ones do? What is rasagiline? What's the mechanism of action here? What class of drugs are these? Yep, that's correct. A lot of these questions are tricky in psych because of stuff like this, which is why I'm showing them to you now. Like I purposely found questions that were like a little bit weird with the answer choices, because I want you to remember this moving forward and not make the same mistakes I did when I was going through these. UWorld has a lot of good questions on these. Also like the BRS farm book, but like I said, this is just a mechanism of action question. Because like instinctually you're like, oh, levodopa, you give carbidopa, but especially since they talk about peripheral, right? Like a lot of people would just see peripheral methylation, like, oh, peripheral breakdown, right? Carbidopa. But like, no, you got to think about it for a second. Really got to think about it. Yep, you're right. It is. It's inhalants, right? Um, this is a dead giveaway, but they might not be that kind to you. Also, short does not happen for long, right? Seems drunk, not drunk, seems drunk. Slurred speech, approximately 15 minutes, right? The other thing too, they don't have it highlighted here for some reason. Alternating palm movements, dysdiadechokinesia, right? Do they have it down here? Yeah, ataxia, right? Um, Something to point out also. 15 minutes. You smoke a joint, you high for 15 minutes. You do a couple bumps, so you're high for 15 minutes. If you are, you better go talk to somebody because they ripped you off. Alcohol. I wish my not drunken nights only lasted 15 minutes sometimes, right? Please be no. This is also should be a dead giveaway. Please no, please no. Inhalants wildly short duration of action, wildly short, and it should make sense, right? Because like, what is your body going to clear faster? An inhaled gas or some substance that you physically intake in and now has to go through either like hepatic processing or renal excretion, right? Like you're going to breathe inhalants back out. You can't breathe out drugs. This is Wilson's disease. Why is it Wilson's disease? Well, he's 28 years old. He's 28. So D, no, not D. He's 28 years old. So it can only really be Huntington's or Wilson's disease, right? They give you these labs. They tell you that his Hep B surface antibody is positive. His AST is through the roof. Does this person have hepatitis B? No, this person does not have hepatitis B. Why? He's been vaccinated against it, but he doesn't have it, right? They're laying this as a trap for people who don't know. Someone who just doesn't know probably sees hepatitis B and says, "Oh, give him an Ovir," right? But the seroplasmin, they gave it to you right here, right? It's low, so it has to be Wilson's disease, right? But how do you fix metal poisoning? Any of the metal toxicities? Just give me like the general class of drugs. Yeah, you give chelating agents, right? Penicillamine is a chelating agent for copper. Penicillamine. Yeah. This is really high yield. I'm pretty sure I have this like start ending green on that slide. Please know that you treat Wilson's disease with penicillamine. Actually, one of the other questions we did about Wilson's, I'm pretty sure it told you the person was taking penicillamine. Yeah, but yeah, please know this. Please, please, please know this. This is usually the Wilson's treatment they're gonna ask you about. Oh, this is a fun question. It's meth. It is meth. It is meth. You're also on the right track, right? However, I'm going to give you a little hint. This is the reason why cough syrup this is the reason why a lot of allergy medicine is kept in behind the counter now and in glass cases because you use pseudoephedrine to make meth. You use pseudoephedrine to make amphetamines. Yeah, those wise men kind of. Is this Huntington's disease? Yes, it is Huntington's disease. How do you know it's Huntington's disease? Father had dementia in mid 40s. guy's 39. Right? And then you have the ataxia, the dementia, all that stuff, right? Atrophy of the striatum, specifically the caudate nucleus, right? Generally, for these questions, notice a pattern. 20s, Wilson's disease. 30s, Huntington's disease. Older than that, it's dementia, right? You should be able to tell me what disease this is before you actually like answer the question. It is polio. Yep. And they're very kind to tell you that the interior horn of the spinal cord is destroyed. Yep. So this is a upper or lower injury. It's lower. So lower anterior horn injuries are considered lower motor neuron injuries because that's where the cell body for the lower motor neurons is, right? That's why polio chills there, right? So any of these, you could have got atrophy, fasciculations, decreased tone, hyporeflexia, all those. How do I know it's polio? Well, they told you it's a 5-year-old kid from a non-Western nation that has not received any vaccines that has leg weakness, muscular weakness, and then the anterior horn cells. Anterior horn cells is like your dead giveaway. Listen, man, when you read 5-year-old boy, not Western nation, unvaccinated, there's a couple diseases you should immediately think they're asking about. Polio. Does it start up and go down? Not really. No, it's just down. It's just like maybe, I don't know, progressive weakness. I always think of polio as like it's just progressive weakness. It typically affects the lower extremities more so than the upper body. And I've never read a source that says this, but I'm pretty sure it's because the lower spinal cord has a much bigger density of anterior horn neurons. And if this virus attacks the anterior horn neurons, it just makes sense that it would be there. So it attacks the anterior horn. It probably infects and then moves, I guess, both up and down. But it starts with weakness, right? It's hard to distinguish because they're kids that usually have it, right? So they start weak and then eventually they just can't walk, right? But yeah, it's very much just anterior horn. If you see anterior horn cells, you should think polio immediately. The only other thing that they could ever be like, oh, the anterior horn cells, like the anterior horn neurons are damaged, would be like ALS, right? And in ALS, you're going to have mixed upper and lower motor neuron signs all over the place, and it's going to be an old dude, right? Older dude, or me, right? Uh, This is weed. Yeah, this is marijuana. Probably edibly ingested. It's probably an edible. Maybe he smoked it. I don't know. But this is weed. All right. So now that y'all know this is marijuana, right? What's the answer? It is G. Yep, that's correct. This is why you can't drive a car on and smoke marijuana. All right, listen. Sometimes you gotta go with the obvious answer, right? It's a college level kid that's paranoid he's gonna get in trouble, right? Weed. He's tachycardic and his blood pressure is elevated. Also weed. A lot of people think that weed like mellows you out, so they assume it like drops your blood pressure and your heart rate. No, it does the opposite. It increases blood pressure and heart rate. This is why when everyone was trying to use like medical marijuana for like anxiety and like treatment of all these diseases in old people, they were like, that's a stupid idea because it causes hypertension and tachycardia. So this is why like you don't use weed to treat things in old people, specifically anxiety. Um, then Cottonmouth and dry red eyes. Oh, come on, man, this is weed. We can, yeah, we can dip through these two, right? Like, so tactile hallucinations, right? This is either shrooms or marijuana or cocaine. Pupillary constrictions, like opioids, right? Synesthesia, or also known as seeing sound, right? That's LSD. Decreased appetite, amphetamines. Slurred speech, probably alcohol. Sense of closeness to others is ecstasy, right? Impaired reaction time, marijuana. This is why you are not allowed to drive a car while smoking marijuana. That's it. That's all I got. That was a lot. Thanks for bearing with me. Does anybody have any questions? No problem, of course. All right. Enjoy your weekends. If you have any questions, feel free to WhatsApp me, email me. You know the drill.